Let's turn now and talk a little bit about the R-squared regimen, so lenalidomide and rituximab. It's been tried in a variety of settings, relapsed, frontline data now. Nathan, you've chaired and been part of a lot of these studies. How do you see R-squared being used in the coming years?
So the R-squared, which is lenalidomide and rituximab, there were several studies that were done a long time ago in different malignancies, for example in CLL, and in preclinical models that suggested that lenalidomide and rituximab were synergistic, and this mainly was due to increased ADCC when you combined a drug like lenalidomide with a monoclonal antibody such as rituximab. The good thing about follicular lymphoma is that we know that this disease is very sensitive to drugs that use ADCC as a main mechanism, things like rituximab. So we've seen data now, as you mentioned, from several different trials, both in the relapse setting and the frontline setting. These are mainly phase 2 trials, which showed response rates, upwards of 80% in both lines, frontline and in relapsed. And so at this ASCO, I'm presenting the data from a study called RELEVANCE, which I didn't come up with this, but RELEVANCE stood for Revlimid versus any chemotherapy. RELEVANCE.
I didn't know that either.
Yeah.
That's new.
So
no one would know if you said you came up with it.
Yeah. So, but this study was again based upon some phase 2 trials that we did at Anderson several years ago. But the study enrolled around 1,000 patients and randomized them to receive lenalidomide rituximab. These are untreated follicular lymphoma patients with GELF criteria. To receive lenalidomide rituximab versus rituximab plus chemotherapy. And although the study was built as a superiority trial, and it did not meet its primary endpoint, that we didn't see a difference, honestly, in long-term progression, well, I say long-term, 3-year progression-free survival with the two arms. They were essentially identical with the lenalidomide rituximab or rituximab plus chemotherapy. So I think that data like that would suggest that that's a real viable option for patients, especially patients that are maybe looking for a regimen that doesn't include traditional chemotherapy, because again, the disease control appeared to be very similar. We do have a study coming out soon, which I think John is very involved in, called the AUGMENT trial, which is going to look at lenalidomide rituximab versus rituximab in a relapse setting, and that data has yet to be announced.
So do you see a lot of the uptake in the front line with R-squared? Do you think people are still going to be using it in second or third line?
So I'm obviously a little biased.
Well, we'll get everyone else's opinion here in a minute.
So I mean, I think it's a great option for people in the front line. Again, with a lot of these new therapies, and we talked about this with idelalisib and copanlisib, there is a learning curve, and I think once physicians kind of understand the common toxicities of lenalidomide, it's very manageable, and many of our patients, including patients that have very high tumor burden, go into complete remission or very good partial remission with long duration of response with the regimen. And I have patients that, for example, I have college students that have continued throughout the semester or played sports or done things well on therapy and achieved the same remission as if they've been on R-CHOP or R-BENDA. So again, I'm a bit of a believer, and I know that I'm clearly biased because of the work that we've done.
But before I get other people's opinion, let me ask you though, so with myeloma, there's a issue with second malignancies. Any signal in these studies?
So we saw no difference in, so if we look at the second primary malignancies, there was no difference with lenalidomide rituximab compared to our chemo in the randomized trial.
Okay, Matt, in Nebraska, are you as bullish on R-squared in the front-line setting, or?
I think it's going to just make the discussion longer because you have another option to discuss. And
Thank you, Nathan.
Thank you for that. 41 minutes now.
Right.
Because it's kind of getting back to where we are in CLL when we're discussing things. You now have something which would be considered a longer treatment, months, to a finite duration therapy. and people are going to self-select out which one they want, and you're going to tell them here are the advantages and the disadvantages. You know, I worry about the cost of lenalidomide rituximab long term, because I do see patients post myeloma post auto, you know, until toxicity progression, or they don't want to take it anymore, can't afford to take it anymore. And I think that needs to be kept in mind also, because one of the things you don't want to do is kind of be half treating people, even in the front line. And I know you probably were going to say, okay, if they get a relapse, it's probably not going to matter into the second and the third. But again, we don't have long-term data in how this could change the disease from that standpoint. So,
How do others feel, John?
Yeah, I think it's certainly a longer discussion. I think you know, the data certainly are suggesting that R squared could be useful for patients even if they have adverse prognostic features or bulky disease, which honestly is a little bit surprising to me. So in those patients that you might be giving BR2 or R-CHOP to for a non-transformed setting, this might be an option to consider. I think in follicular lymphoma, I mean, the good news is it's another option for people. And while we'd like to see better efficacy, having the same efficacy with a different toxicity profile allows the patient to choose that issue. The hard part is these are quality of life things, and patients and doctors have impressions about what's going to give somebody a better quality of life, and I think that's one of the messages probably throughout all of our discussion today, is that since most people with follicular lymphoma are not going to die of their disease, it's all about quality of life, and we kind of help patients make these choices, but the tools that they have to kind of make those choices are limited. And I think this is one example. Well, for some people, they would have a very good quality of life, and others, they wouldn't, because it'd be an ongoing therapy with some nagging toxicities. So I think that's something that people just are going to have to navigate in these ever elongating discussions.
So are you thinking the same way here, or what?
You know, when I was part of Alliance, and John is the person who wrote all these studies, we also had some frontline studies with lenalidomide and rituximab, and you know, when you see some of these responses and then you see the data that Nathan showed, you know, I think it's absolutely an appropriate option. And the nice thing about the way, you know, both the Alliance trials and the MD Anderson trials and now this international trial is that it's not indefinite lenalidomide. You know, I think that's a really key point. When we think about the myeloma world, you know, people are on this drug for years and years and years until, like Matt said, they have progression or toxicity or something like that. Here, you know, it's 18 months at most. And, you know, in the Alliance trials, it was 12 months. So I think that makes me more compelled to think about this, you know, as a biologic therapy that induces deep remissions and allows a good quality of life. And yes, there is this concern about second primary malignancies, but you know, I think people who have one cancer already have an increased risk of second cancers, and how much more a year of lenalidomide adds, I really don't know. So I'm glad to hear that it wasn't any different in the randomized setting.
So changing